thankfully I'm starting anyways. So hopefully she will be able to join us by the time I'm done. So I'm Lisa, I'm a physical therapist here. I'm board certified in neuro. I also have my brain injury specialty. Vestibular and migraine management is my big background, and kind of how I got into concussion. I consult with all 8 of our other Kinetic Edge locations, as well as with other healthcare providers, whether that's PT, obviously speech, OT, eye doctors, your regular physicians, neuropsychologists, so I kind of talk to everybody. And we'll talk about the importance of having those people on your team today. So the big thing is, what is a concussion? So the most recent concussion consensus is just, it's a traumatic brain injury caused by a direct blow to the head, neck, or body resulting in impulsive force. So the big takeaway from that is it's not just hitting your head. It's usually like an impulse that causes your head to do this motion or this motion. So it doesn't have to be hitting your head. So if you're in a car accident and they're like, oh, did you hit your head? And you say no, that doesn't mean you don't have a concussion. And the same thing with a fall. If you have a pretty significant fall and you don't whack your head, that doesn't mean you don't have a concussion. So that's always really important to note, that you don't have to hit your head. So this is, my original lecture was tailored towards athletes. The symptoms are the same, so I just kept the same slide in here. You can feel dazed, confused, a little stunned. You may be slow to answer questions. You may repeat questions. You may have horrible recall. A lot of people have some, like, a little bit of amnesia around the time that they hit their head, where maybe like they knew they fell, but they didn't know they hit their head. Or maybe they don't recall the next couple minutes afterwards, or even a couple minutes before. You can lose consciousness, but that's not required for you to have a concussion. So not everybody loses consciousness. You can have behavior, personality changes. Some people are irritable, a little bit more aggressive. And then like with school or work, just like forgetting your schedule, forgetting to get things done, things like that can be like initially observed. It can also go on later in more chronic cases. And then symptoms that you might be reporting are a whole host of cognitive, emotional, physical, and sleep related. So it's not just a headache and dizziness. You can be really tired, you can have double blurred vision, light sensitivity, noise sensitivity, you can just feel off. What comes with a concussion is a whiplash injury. Every single time if you have a concussion, you have to have a whiplash injury, because of the fact that it takes less force to cause whiplash than it does to take a concussion. And so a lot of people have neck pain, neck stiffness. You might have radiating symptoms into your hands that goes with that. You can also have the cognitive part, where you feel like you're slow, you're having difficulty processing, you feel like you're foggy all of the time, decreased memory and concentration. Emotional is irritable, sad, anxious, nervous, mad, lots of different things. And then it can affect your sleep. It can make you sleep more, it can make you sleep less. It can interrupt your sleep, so maybe you fall asleep really well, but then you wake up frequently after a few hours. So it can do a lot to our systems. So it's not just like I hit my head and my head hurts. There's a lot more involved, because a concussion is more diffuse through your brain, and it's an energy demand. And so what happens when you get injured is those axons that connect your nerves together, they shear, and then your body tries to repair that and sends in a lot of different nutrients and neurotransmitters to make things recover. And then we have to do, on the PT side of things and the physician side of things, is we need to get things back up and running again. So usually I correlate it to like that pathway's under construction, and so then you have to use other pathways to do the same task, and that burns energy and is harder. So things that seem like they should be really easy for you are actually harder because of the energy demand that's taking to do them. Concussions, one of the big points is they are functional, not structural. If you have structural, you have a more severe brain injury, whether it be a higher level mild traumatic brain injury, moderate, or severe. Those ones have structure damage. A concussion does not, in the way that we can test them right now. So the way that we do imaging and do testing, you cannot see any structural damage with a concussion. And then other causes of concussions outside of athletes: falls, motor vehicle accidents, assaults, blast injuries, which are more prevalent in military but can also happen in everyday life. and then just like collision struck by an object. I had a girl who was doing a TikTok video, and her friend kicked her leg out from underneath her, and they were on ice, and she fell back and smacked her head on the ground, and actually had video of it because it was for TikTok. So lots of different reasons you can have a concussion. You can get hit in the head by a ball, you can fall, lots of different things. So then diagnosis. If you're an athlete, you're going to get removed from play. They're going to look for signs and symptoms. Schools should have an athletic trainer or a healthcare provider on site if it's an Iowa sanctioned sport in high school. Whether it's if you're away, it's the opposing team. If you're home, it's your team that does the coverage for it. They should be screening them and doing testing for that, and going to the emergency department if they have red flags. If you're not, that depends. If you're in a motor vehicle accident, they're often going to ask you if you feel okay. Your response is probably going to be like, yeah, I feel great, because your endorphins are through the roof, and things feel pretty good, but symptoms tend to come on later. And so what I see a lot of is if you have a concussion, your symptoms are usually pretty prevalent. First thing, you're dizzy, you have a headache, you're nauseous, all the things happen. My people who have more of a whiplash injury tend to have delayed symptoms, like a day or two delayed, because of the way that our necks process sensory information. Part of that shuts down with a whiplash injury and can take up to 2 days to come back online. And so usually those are more delayed response in symptoms versus concussions tend to be more prevalent within the first day. Either way, we always say if it's an emergency, if you have really high symptoms, if you have red flag symptoms like you can't talk, you can't walk, all of those emergency things, like you need to be going to the ER. Otherwise, most people will rest 24 to 48 hours, see if their symptoms come down with relative rest. So reducing screen time, hanging out at home, doing gentle things around the home, but just trying to in general relax. And then if symptoms persist past that point, checking in with urgent care or your primary care physician is a good choice. Physical therapy is direct access, and for me, I'm specialized in concussion, so I love when people walk in within a few days and say that they got injured, because I can do a full screen and then bring in a provider that's specialized instead of seeing like an urgent care doc or a PCP that may not know anything about concussions. So I love being the first line. That works really well if you have a direct access insurance plan. Medicare, Medicaid aren't direct access. They require a referral, and some of the other smaller ones do too. But it just depends on your insurance, and we screen that, so that's something we look into. So I do like getting people sooner rather than later, just because they recover faster. And then ER, so these are all of our red flag symptoms, like you have pupil changes, you can't be awakened, which is the whole hallmark of like don't go to sleep, make sure that you can wake them up and things like that. You can rest, we just tell you to check on, don't be alone and have somebody check on you a little bit, make sure you're breathing. Worsening headache, numbness and tingling, decreased coordination, vomiting, nausea, slurred speech, convulsions or seizures, difficulty recognizing like where you are or who people are, confusion, restlessness and agitation, and behavior changes and loss of consciousness. So those are all red flags. Those are where you're going to the emergency room and need to be seen. This is Cassie. So the first 24 to 48 hours, like I said, relative rest, limited screen time, activity should be limited. It should really be limited to your symptoms. So like if you can fold a load of laundry with no symptoms, like go ahead and do that. But if you do something and it starts to make you feel worse, you need to take a break and find something else to do or rest. The goal is not to make your symptoms build. And then obviously avoid getting hit again. The amount of people that I know that get hit a second time just because of random occurrences. Like I had a client who was sitting watching her kid shoot baskets and it ricocheted and bounced off the garage and then came down and hit her, and she was like 25 feet away. So like for some reason your heads are magnets once you already get hit. So just be careful. After 48 hours, it's really dependent on the person. If you're working, is anybody here working with schools or anything like in school? I don't see anybody young enough. Okay, so if you are in a school, it's usually ATC and nurse driven. If you're not in school, then that really is where you're going to return to a physician, urgent care, and if your symptoms are really bad, you're going to go into an ER. The problem with going to an ER is they're gonna say you have a concussion and they're gonna send you home. Because it's not an emergency once they diagnose that it's a concussion. Once they realize, they do a CT scan and say, you don't have a brain bleed, you don't have a skull fracture, you have a concussion, they're gonna send you home. And oftentimes they send you home with no additional guidance on what to do next. And that can be a problem because then you're kind of stuck. And you're usually pretty symptomatic at that point because it took you to the ER. So urgent care and PCPs are better. Later on I talk about my preferred is a sports med doc. After 48 hours, we do school modifications, work modifications, we do a lot of education on symptom management, and then pairing up with providers. So I'm going to skip baseline testing just because nobody in here is doing it. It is really important if you know anybody that's an athlete in school. I don't care what sport they're in, they should be getting baseline testing done. It gives us a lot of information that we can go off of later for them. So then other providers that I coordinate with, sports med physicians is probably my number one. And then athletic trainers, other physical therapists. I do a lot of consulting for around Iowa, more rural areas, so I will do a full hour consult and then send them back to their PT wherever's closer so that they can do their care, but I coordinate it by doing phone calls and emails and making sure that they're on the right track, because often rural PTs don't have the education, the additional education on concussion management. So I don't want to make people that are symptomatic drive multiple hours if I don't have to. So if I can find a PT to work with closer, that always works out really well. Occupational therapist, speech language pathologist is not on here, but it should be, because she's going to be speaking. Neuropsychologist, ophthalmologist, optometrist, physiatrist, and psychology and psychiatrist. One of the big things with concussions is they exacerbate things that are underlying, which is why I often work with some of these other ones. So if you have an underlying astigmatism that maybe doesn't need correction prior to a concussion, it's gonna need it after, even if it's just to get you past the concussion, because it's just a huge energy demand for your eyes to correct for that. If you have underlying anxiety and depression, that is going to be amplified post-concussion, and so your meds may need to be modified. You may need to add meds if you were able to cope and manage prior. And so there's a lot of conditions that can be underlying. Migraines get exacerbated post. So working collaboratively with other providers to help manage those conditions is really important. You can't just go to PT and hope that the other conditions go away. So it's really important to have a team. So then when can you see, if my part is, as I'm a physical therapist, is when can you see me? I can be brought in at any time. I prefer to be brought in the beginning because it's easier for me and people recover faster the faster they're working on their recovery. Because a lot of times you don't know what's happening to your body. And so if you don't have somebody helping you and guiding you through that recovery and what you can and can't do and how hard you should be pushing and what may be triggering your symptoms without you even realizing it, that can make your symptoms persist a lot longer. Also with the concussion, like the whiplash component, treating the neck dysfunction that comes with whiplash, that also usually doesn't just go away on its own. Our bodies are really good at compensating until they can't. So oftentimes I'll get people who will say that they don't have neck pain, and then I'll put my hands on their neck, and their neck hurts. And so it's a lot of like our brain being like, that's just not important right now because we have all these other symptoms. But it is a problem and we do have to address it. So I like being brought in sooner, but I also have clients who come 2, 3, 4 years later with like they've gotten 70% better, but maybe they're still on disability and still not working and they just want to get more out of it. The hardest part is people who have desk jobs and have to be on a computer all day long because that visual demand is really taxing to our systems. And so if then maybe they can function in the day-to-day, but they can't do their job because they can't tolerate the 8 hours on the computer. So just trying to find ways to get in there sooner rather than later, making modifications where we can, and teaming them up with people that can help them get better. And then, why do you do physical therapy? So for me, I'm board certified in neuro, I have a brain injury specialty, and so I know to look at multiple systems, and I know it's not just a headache and it's not just dizziness. So I screen the neck I make sure that I educate you on how to manage your symptoms, because even if we can't make everything better at once, we can reduce symptoms. So like one of my big ones is an ice pack on the back of your neck can make your dizziness and your headache less. Ginger chews or sour candies can help your nausea. If you were here when I first plugged in, my computer looked green, and that is because I have a nightlight on my computer because I can't tolerate all of the white bright light on my computer. And so I turned the nightlight on and my computer's a little bit more yellow. So it made the blue a little bit more green. Doesn't bother me because my eyes love it, but it made the TV screen look really weird. And so if you don't know those exist or how they're going to help you, then you don't use them and you can't manage the symptoms to try to just get you through until you can recover. So that's really important for PT as well. And then because I work with a lot of people, I can refer out to people that maybe you didn't think of that could help you on your collaborative care team. And then I frequently text the providers or email the providers I work with to make sure that school and work modifications are as good as they can be. So this is just my screen about post-concussion syndrome can look like whiplash. They are virtually identical. And so if you have a doctor that's saying you have a concussion and nobody's touching your neck, that is a huge problem because they look the same. And it takes less force to cause the whiplash than it does to cause the concussion. And then for my evaluation, like we do a subjective report where you just tell me what happened and what's going on. We do a symptom checklist so I can see where you sit with your symptoms. I always make sure I check your cervical spine, which is your neck. We do VOMS testing, which is vestibular ocular motor testing. And so it's a lot of visual and head movement. Hi. And we do that testing that's more of a neuro exam, that all of your visual motion is controlled by your brain. And so we do the ocular motor. And then the vestibular, sometimes that's tested in the beginning, sometimes I hold. If you have a whiplash component, you're not gonna like to whip your head back and forth for a VOR test, which is literally staring at a target and doing this really fast. If you have whiplash, you're gonna hate that. And so you're gonna test positive whether you have a concussion or not, because your neck doesn't like that. So oftentimes I will, unless you're doing really good, I pass that to the bottom. And we come back to that when the neck is feeling better. We do balance testing. We'll do aerobic, so a lot of times I start, I'm like, we have a recumbent bike or a new step. Treadmills have a lot of impact, and if you have a whiplash injury and you're on a treadmill, you're gonna feel like garbage just because of that. And then if you don't have a neck injury and you're on a treadmill, but you have a vestibular condition, you're also gonna feel like garbage because your surroundings are not moving while you're on a treadmill, and so that's mismatched sensory information, and our brains can't really tolerate that in the middle of a concussion. So I rarely start on a treadmill unless I get somebody a little bit later in their recovery and they're ready to hop on that. And then we do a lot of education, like I'm doing right now. The big thing with concussion is doctors spend a lot of time pointing out these 7 circles. You don't usually have just one. Most people have about 3 where their kind of concussion is kind of heavily sitting. You may have all 7 in the beginning, and then we kind of tease out a few and kind of narrow down where you're really having problems. And we do the symptom management to figure that out. And then I also wanted to talk a little bit about occupational therapy. My occupational therapist is on maternity leave, and so she's not here to join us and tell you more than I'm going to tell you on this tiny slide. But our occupational therapist here at Kinetic Edge, they do sensory integration and primitive reflex integration. And Tessa does a little bit more of the in-depth vision specialized. So like if I need to do a lot of neck and balance and aerobic, I will co-treat with her so that we can take a break, and then you can come back and see her and do vision. That way we're not doing everything all together. So she'll do a little bit of vision and sensory integration in her sessions. And the real reason I highlight the primitive reflex integration is when we have an injury, we kind of go into our animal brains, which is why like word finding and concentration and memory and attention kind of decline, because those are not important for survival. And so then some of our primitive reflexes from when we're a kid can pop back out. And that's a problem with recovery, because that can cause, especially in the neck, some tone issues that we need to address. So not all of my clients see occupational therapy, but a lot of my clients that have prolonged issues and they've been in this heightened sympathetic response and heightened issues with symptoms will definitely need OT and PT at the same time.
Yeah. Okay. I'm Cassie. I am a speech language pathologist, speech therapist, and I own Connect Therapy. So I've worked with the PT and OT here at Kinetic Edge, and I'm going to talk to you about the speech therapist role in concussion and speech language pathology. I think usually when people get a referral to speech therapy, their first question is, or their first comment is, oh, my speech is fine. And yeah, usually it is. And so speech therapy, what I'm going to go through first is like the role of the speech therapist, and especially with adults, and I feel like with concussion or with brain injury, the speech part of it is a bit of a misnomer. Of course, we work with speech, and if you're having some difficulties, the part of your brain or the motor neurons that were impacted where maybe your speech is a little impaired, that, of course, is something we would address, but it's way more than that. So, a speech-language pathologist treats speech, language expression and comprehension, voice, stuttering, auditory processing, and swallowing. And then the other side, cognitive communication. So that's all of the cognitive processes or thinking processes that are related to communication. And our brain is so complex, and language is so complex that you might not be having difficulties with speech or even word finding, but you might be having difficulties with attention, memory, executive functions, and then those are impacting your difficulty with communication. Those are impacting your daily life, your return to work, and it's not word finding, it's not speech. Who do I see for that? Speech therapist. Okay, so going through cognitive communication a little bit more. So the executive functions, working memory, mental flexibility, organization and problem solving, time management, inhibition, self-monitoring, and attention shifting. Those are all included in cognitive communication, and those are all things that we can treat. I don't know if Lisa covered this, but the difference between concussion and TBI. Okay, so
depth like that. No.
Okay, so I feel like usually speech therapy gets involved if you have concussion and you are experiencing some of these symptoms in the first 24, 48 hours, and then they start to resolve. Wonderful. Speech therapy is not for you. But where speech therapy and where I see more need for speech therapy for most folks is when we get into that more mild TBI or moderate or severe brain injury after the concussion. So I like to kind of throw this up there as, like, this is how they categorize it, okay? So we have two different kind of areas. We either have a loss of consciousness or cognitive changes. To classify, is it a concussion and a mild TBI, or is it more moderate and severe, okay? So loss of consciousness less than 30 minutes, and then the cognitive changes that we might see. We would expect confused and disoriented, but that lasts less than 24 hours. Memory difficulties also lasting less than 24 hours. If it's longer than that, we get into the moderate TBI range. So you could have had loss of consciousness for 30 minutes up to 24 hours, or you are confused and disoriented for more than 24 hours. You have memory loss lasting more than 24 hours, but less than 7 days. Then you'd be in this more moderate range. And then we have severe. Loss of consciousness for either more than 24 hours, or you are confused and disoriented more than 24 hours and your memory loss is more than 7 days. So the role of the speech therapist with concussion and TBI is to evaluate for a cognitive or communication difficulties following concussion. Also language and swallowing, but cognitive communication is where I see more issues. Develop a treatment plan, assist with your return to work or return to daily activity plan, recommending and advocating for whatever accommodations or modifications you might need on your journey to return to work, and then also consulting and collaborating with your PTs and OTs that you're working with. And at Connect Therapy, and I know you guys do too, I mean, we do one-to-one sessions, so you get individualized intervention. Okay, this is a very long slide and it's a little overwhelming. But when should I seek out a speech therapist? Okay, great. I know I need PT, maybe I need OT. When do I need a speech therapist? Okay. So, first, if you're having difficulty communicating your needs, you feel like, okay, I can get across my basic needs and wants, but if it's a more complex topic, and I'm having difficulty either expressing exactly what I want to say or really even understanding or following a conversation that I would have been okay with before, that's where you need speech therapy. A reduced awareness of your impairment. So if the person with a brain injury does not see the same thing that their care partner or their PT or OT is seeing, there's a mismatch in their awareness of the impact. That would be where a speech therapist might be helpful. Reduced memory, judgment, ability to initiate and effectively exchange information, personal lifestyle management. Okay, so managing finances, driving, following directions. Even like following a recipe, cooking, that sort of thing. Reduced ability to anticipate potential consequences with reasonable judgment and problem solving. So are they making decisions that aren't sound or aren't like them? Reduced social communication skills or difficulty managing that inhibition that I talked about earlier. Disruption in your ability to complete your education or your work roles. Potential loss of employment. I've seen people even a year after concussion or brain injury where they've lost their job because they can't perform in the same capacity that they did before, and there were no accommodations made, there was no like baby steps taken to get back to work, and really a speech therapist can still help you 1 year out. Okay, the brain is amazing, we can still continue to make improvements at a year out, but that's where a speech therapist role would come back to that gradual return, so that when you do start working again full time, it's when you're ready and your brain is really ready to get you back where you were. At risk for injury due to inability to communicate. That's more severe, of course. If speech is difficult to understand, if you have a new voice or stuttering difficulties, and then swallowing. So if you're noticing that you're coughing or throat clearing more frequently after a brain injury, there's likely a chance that your swallowing is impaired or your swallowing is impacted. And it might not be choking that is the difficulty, but you might feel like something's stuck all the time, or you might feel like you have to clear your throat after you have a drink of water and that's not normal, or you feel like you need to cough more during a meal. That would be, your swallowing is controlled by your brain. And so that could be part of the issue as well. And we can rehabilitate the swallow. That's very long. Okay, so what does a speech therapy session involve? My sessions are 45 minutes. My evaluation is an hour. I provide a little bit of extra time just for us to get to know each other and really figure out what's going on. And we do go through a formalized cognitive assessment, but also kind of work together to develop your goals and plans and what you want to get out of speech therapy. But what you can expect, this is going to be a little different for everybody, of course, but generally what you can expect is kind of guidelines or recommendations on a gradual return to normal activity. Strategy, training, and implementation. I don't really use worksheets, but I teach you different strategies based on what is going on, and then you implement them, and you come back, and we problem solve. What worked, what didn't, what should we tweak, what should we not. Attention building, executive function building, recommendations and advocacy for return to work modifications. Most employers are really understanding, but some are a little bit more difficult to work with. And I always like to tell people this, it's typically very short term. Once per week is what I would recommend, so we have that consistency. But for most people that I see with concussions, doing like outpatient or private practice speech therapy, 4 to 8 weeks. Okay, if we have a more severe case, longer. But 4 to 8 weeks is typically where we're at. Okay? That's all. Cool. Thank you.
Yeah, so we're just going to open it up to questions then for either one of us.
Yeah.
Does anybody have any? Okay. Cool. Oh, what's up? Yeah? I love questions, so if you have them.
Cranial physical therapy basically just is all of what you explained. Would that be correct for what you do?
Can you rephrase that? So cranial, as in like neck work, or craniosacral work, or all of it? Yeah, so for neck work, Whiplash injuries, you may have reduced range of motion, and so then you're typically going to report that you have stiffness in one direction over another. You're probably going to report that you're sore. So a lot of people will turn their heads and they'll have great rotation to the right, and then you ask them to go to the left and they're like here. And they know that that's a problem, but it's not usually interfering enough if they're not telling you that it's painful, or it is interfering, it's painful and it's stiff. So we do manual therapy to loosen that back up and get the range back. But one of the really big things that I focus on in this clinic with whiplash injuries is getting your deep stabilizers to be active. So often people complain of neck pain because our big muscles, our upper traps, our big SCM muscles, they're doing all the work because they are trying to help out the fact that your neck got injured. And so our brain learns a new motor pattern, and that motor pattern is that we overuse these muscles. And it can turn into kind of like if you ever see like a little baby that has torticollis, where they're like a little bit leaning or a little bit over. It might not be as dramatic, but you're going to have like a natural tendency to have a tightness on one side because our stabilizers are usually one-sided that they kind of shut down. I find that it is usually correlated to how they were injured in the first place, whether that was like a sideways, so this side decides to take a nap for a little bit. But either way, our brain turns on like a new motor pattern. Instead of our stabilizers kicking in first and then our big movers kicking on when we move, they kick on together. And that means all of these big muscles that are supposed to be more movement muscles become our endurance muscles, and that's not how they're built, and they get really sore. So I do a lot of stability work, and to a lot of people that feels like nothing, and they feel like they're not doing anything until we start getting things firing, because it really is nothing. The muscles are very small. But we need them to kick on before your joint moves, or you're gonna get a danger signal to your brain that tells you you're dizzy, or it's gonna give you a headache because the wrong things are kicking on at the wrong time. So we spend a lot of time getting those stabilizers to turn on. We do a lot of postural stability exercises where maybe we get these muscles to turn on a little bit more so that these ones can take a break. I also coordinate a lot with our orthopedic therapist if you're in a motor vehicle accident or have a fall and you also have a back injury, a hip injury, a knee injury, because it all plays a role in all of it, and we need to address it. If you can't lay flat because your back hurts, I can't really work on your neck and your stability, and so we have to coordinate care. Any other questions? That was a great one. Thank you for asking. Cool. We can wrap up, and if you have individual questions you want to ask, we'll be hanging out, and you can come up and talk to us. Yes, there is a form. It's a disclosure that says like this is in medical